Welcome everybody to the PrecisCa Genitourinary Oncology Tumor Board. My name is Brian Reaney. I'm a professor of medicine at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. And I'm pleased to be joined today by a panel of experts, and we're going to talk through a number of kidney, bladder, and prostate cancer cases.
My name is Jason Abel. I'm a surgeon. I'm a urologic oncologist and associate professor at the University of Wisconsin.
My name is Maha Hussain. I'm a geomedical oncologist. I'm a professor at the Robert H. Lurie Comprehensive Cancer Center, Northwestern University, and I also serve as the deputy director for the Cancer Center.
Hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I specialize in abdominal and pelvic imaging as well as nuclear medicine. I'm glad to be here.
My name is Preetish Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University, focusing on GU malignancies.
So this is to summarize, a 51-year-old man who presented with a solitary brain metastasis, underwent resection. Path was consistent with metastatic RCC. Had recurrent disease, unfortunately, to the multifocal brain areas and spinal cord. Got radiation to those areas. Started on ipilimumab, nivolumab with excellent response, and had no evidence of disease outside the primary tumor, and actually underwent a palliative nephrectomy. So we should talk about the role of nephrectomy after 2 years of maintenance. And the question is what to do now in this, what I would say, very unique case. So just to go back, this patient presented with left arm weakness and had head imaging, as you might imagine. And we see here on MRI of the brain, I think even I, as a non-radiologist, could read this, has a right frontal mass with some edema. I don't know if Dr. Fromm, if you want to reinforce my budding radiology skills for what you see here.
Yeah, so on the left side, we have a post-contrast Q-unweighted coronal image showing an enhancing lesion with kind of a ring-like appearance in the frontal lobe, and the image on the right is a T2-weighted transaxial image that shows vasogenic edema within the white matter involving the right frontal and parietal lobes. So, in a patient presenting acutely with neurologic symptoms with this finding, certainly, metastasis or primary, glioma would be in the differential, but you would also consider other things sort of depending on the history and risk factors. This could be, an abscess, neurocysticercosis, things like that. Even like inflammatory processes like tumefactive demyelination would be in the differential. So, without a known malignancy, malignant processes would still be high in the differential, but there would be other things to consider as well.
Sure, thank you. So this patient does undergo resection, as often happens here for both diagnostic and therapeutic reasons. As it's a metastatic carcinoma, it's positive for pancytic keratin and also PAX8, which is a fairly RCC-specific marker, suggesting that this came from a primary RCC. As you can imagine, the patient then had other CT scans to look for that primary and has an 8-centimeter renal mass, but no other evidence of other distant disease. Repeat brain MRI 6 weeks post-craniotomy showed a tiny enhancing nodule adjacent to the surgical bed, and the patient underwent radiation to that area and was scheduled for a left nephrectomy 4 months after craniotomy. And then 1 day before the surgery, had due onset left hand tingling and weakness, and unfortunately, brain MRI now shows multiple new lesions in bilateral occipital lobes, and the patient unfortunately has blossomed with disease elsewhere. Let me back up before this sort of further recurrence and ask Dr. Abel. I've certainly had patients who have solitary brain mets that I've taken to nephrectomy, but I'm always really nervous about doing it for just this reason. This patient's obviously a dramatic example. What's your institutional practice? What's your personal opinion about this kind of patient where you're doing, in essence, a debulking nephrectomy, but they have sort of a high-risk metastatic site, like, say, lung or liver or bone or something?
Yeah, I think that's a great point. I think that a lot of data, continues to evolve over the last 10 years with something like this. It's tough in a patient who is young and theoretically, I mean, this patient, you couldn't quite see that right away, but theoretically has no sites of disease after the craniotomy and radiation. But I think when we discuss that with patients, we discuss the lack of evidence and really the really small chance to be curative with surgery. And I think we really have to discuss about the goals of what we're doing. We are removing the majority of the tumor in their body. In this patient's case, that would be the case. We're also removing something that is a site of further metastatic. Those are both kind of more theoretical. And so I think we're all nervous when we do something like this. But I think in the absence of a lot of other sites of disease, I still think in a young patient, this would be a more typical treatment that would be offered at most tertiary centers.
Yeah, I agree. I mean, I think, depending on age and fitness of the patient, I think, one point that happened here that I maybe didn't highlight going through is the nephrectomy was 4 months after craniotomy. So there was a bit of time for this to play out and be comfortable or not that this patient wasn't going to blossom. Unfortunately, this patient did, but I think rushing this patient to nephrectomy 2 weeks after craniotomy would have been a big mistake in retrospect. So letting a little time play out and letting the natural history play out is probably a good thing. So again, this patient has sort of multifocal systemic recurrence, undergoes radiation to these new brain lesions, and then starts on treatment with ipilimumab, nivolumab. As I think the audience knows, a CTLA-4 and a PD-1 inhibitor approved in, I think, in the US early 2018. So I don't remember the timeline of this patient, but presumably right around that time. Is a month into treatment, so probably just 1 or 2 of the induction doses of both medicines, develops new onset left lower extremity lesions, gait instability, and unfortunately has these now sort of further brain and now spinal cord recurrence / progression. Gets treated with whole brain radiation and radiation to L1 to L3. Let me ask Dr. Patel. I'm a big fan of gamma knife to brain lesions in kidney cancer. I'm not a big fan of whole brain. When do you turn? Like, how many lesions are just too many to do stereotactic radiotherapy?
Yeah, great question. That also continues to be a moving target for how many is too many. We've got great tools now actually to be able to target many lesions all at once, where the patient's not even on the table for hours and hours like it used to be. So it's certainly not unusual to target 10 lesions. I think I see that pretty commonly nowadays, and maybe even higher. There are some ongoing randomized comparisons of targeting a large number of lesions, 15 or more, with SRS versus at some point pulling the trigger for whole brain. But of course, the toxicity profile is wildly different between whole brain and SRS. But you've got to continue to screen after SRS because particularly as the number of lesions increase, you're pretty sure you'll find more down the line. But it's really a quality of life issue.
Yeah, I'm not sure what the right answer is. I think institutionally, when I was in Cleveland and now at Vanderbilt, I mean, our tolerance to do more and more SRS has certainly gone up.
Yes.
We're now into double digits, and we have, frankly, obviously much more effective systemic treatment, as I think this guy is going to be a proof of, an example of.
Yeah.
So yeah, I think it's just a moving target, as you say. So this patient, after this radiation, now gets imaging and is actually responding in terms of his lung metastases, finishes out his induction ipi-nivo, which is up to 4 doses of both medicines, and then gets nivolumab maintenance either every 2 or 4 weeks. And then now it's about 1.5 years after diagnosis, and really quite remarkably, and I think an absolute testament to the efficacy of modern doublets in kidney cancer is he has no evidence of disease except for the primary tumor. So presumably brain and spinal cord are stable by MRI, and lung nodules and whatnot has all disappeared. He just has a primary tumor left. Let me go back to Dr. Abel. We face this now in clinic, not as much as we'd like, but talk about the role of consolidative nephrectomy. What's your, again, personal sort of institutional, when do you pull the trigger? What's too early, what's too late? What's sort of your criteria for patients in this circumstance you might take to nephrectomy?
Yeah, that's a really good question. And I think it's, as we've seen better, some of the combination immuno-oncology agents, we've seen better responses from patients who frankly would have done very poorly years ago. We've seen some amazing responses. I think this gentleman is probably a good example, but there's lots of others, people with huge, volumes of metastatic disease who never would have been a surgery candidate. They come back a couple of years later and they've really had a great response. And maybe there's just a little bit of enhancing tissue left in the kidney or something along those lines. But their performance status has improved, and they're all of a sudden a much better surgical candidate. In those patients, I think we have to very carefully talk to them because we do not have any proven benefit for what we're doing. But as the immuno-oncology agents have enabled responses and patients to live longer and to get to this point, I think it's the same rationale that we've used in the past as far as local treatments for metastatic disease when we've had good responses in other places. And I think, again, I still feel nervous doing something like this, even 18 months out after treatment, because you don't know what the absolute benefit is for the patient. That being said, the morbidity for a laparoscopic nephrectomy is still relatively low in a patient that is healthy otherwise.
Yeah, thank you for that. I agree. It's an evolving field. It's a good problem to have. Like you say, we never really had this problem before, unfortunately. My general mindset for intervention is, am I making the patient live better or longer by doing it? As you say, with nephrectomy, there's no real proof that you're doing either, but it's sort of one of those things that I think kind of makes sense. But in very select patients, just like debulking nephrectomy, right? Up front, it makes sense in very select cases. And I've really only done it a relative handful of times, considering the number of patients I treat. So it's still, unfortunately, a relatively rare patient. But I agree with you. My personal threshold is I like patients on treatment at least a year. I wouldn't consider it before a year. I just think it's too early to know what's going to happen. This patient's 18 months out. So yeah, if otherwise healthy and NED, again, the multifocal brain mets still make me really nervous in this patient. But it kind of is what it is. Time is telling the tale. So I think it's perfectly reasonable. So this patient,
I'm
yes,
sorry, the question.
sure.
This is maybe a comment, if there's room to maybe address that,
Sure.
which is the fact that he required multiple brain radiations. In retrospect, would he have not been better off by having whole brain irradiation to start with? Because I wonder about the damage effect, after having multiple high dose, even though it's focal, multiple treatments there. This may be Dr. Patel and to yourself.
Yeah. I would ask Dr. Patel to comment. I have my opinion, but I'll ask Dr. Patel to comment first.
Yeah, I mean, I don't think we actually have really too much good data to answer that question. Does whole brain, multiple SRS sessions followed by whole brain is the question. You certainly
doing it prophylactically up front, knowing
right.
that the cancer had gone to the brain, why not do whole brain radiation?
Yeah, and that kind of randomized evidence, we do have SRS versus, whole brain or whole brain plus SRS. And those were quality of life studies, and the differences were dramatic. We don't have, meaning dramatic in favor of SRS, but we don't have a lot of data suggestive of really a lot worse toxicity when you've deferred whole brain. In really radiation oncologists, I think we're actually also delaying that really awful CNS toxicity that we see with whole brain. So I don't know of any data there, but maybe as a corollary to your question, I would ask Dr. Hussain, can you maybe talk about the CNS activity of ipi-nivo? And in this case, maybe there's an untreated compartment here. He had radiation to his brain and then the L-spine, presumably with drop mets. Can we count on the immunotherapy to sort of treat the rest of that CNS compartment that we haven't irradiated?
Yes, so there's a lot of complex questions here. My opinion is anecdotally, anytime I've given anybody whole brain, it turns their brain to mush, and 12 to 18 months later, their cognitive abilities are almost zero. Again, it's just my collection of anecdotes. And I would pair with that SRS is remarkably effective at local control, 90+%. So this patient's unusual, actually, in my experience. Most people who do SRS, maybe they have a recurrence a year later and it gets SRS, and that's it. And they pretty much have brain control with their SRS. That's my overwhelming experience. So I definitely wouldn't do whole brain up front, because I think you're actually probably harming more than you're helping. But again, there's not really randomized data, but sort of just the accumulation of clinical. The question about the CNS activity of ipi-nivo or any of the IO-TKI combos is really totally unanswered. In melanoma, there's good data that small brain mets will respond, and you probably can just treat with ipi-nivo. In kidney cancer, we don't have that data. And so I'm of the mindset that any CNS disease needs local treatment before I'll give systemic therapy. I wouldn't just do that. I'm not really aware of any data that would refute, that approach. But really, there's just not a lot of good data. But I think most people probably take that.
Dr. Rini or Dr. Hussein, could you also maybe comment on the fact that it looks like this patient discontinued the nivolumab after 2 years? And again, seeing these good responses and some of the durability, could you comment on the durability and when you switch patients to surveillance alone, or do you keep some patients on nivolumab for a longer period?
Another question that nobody knows the answer to. Thank you for asking that. So really you're asking about duration of immune therapy. How long do we need to continue, one or both components of a doublet, in this case, nivolumab maintenance. So there've been, in kidney cancer, there've been no randomized trials. The studies, Checkmate 214, continued either till toxicity or progression. So there's no prospective data to define that for ipi-nivo, to my knowledge. There are smaller institutional studies going on now to look at it. I think my personal practice, and I think just from hearing from other kidney cancer folks, is, patients get out to 2 years. This patient was NED, so the question was, did they need any nivolumab after the nephrectomy? But let's take a more common patient that has small lung nodules. They're regressed 80 to 90%. They're on maintenance nivo. As I get out to 18, 24 months, I start having a conversation with the patient like, I'm not really sure we need to continue. I've certainly seen people develop long-term toxicity, especially rheumatologic toxicity with maintenance, long-term maintenance nivo. So it's not free, not just financially, but it's, there's a toxicity cost as well, potentially. So I start to have that discussion, and patients generally fall into two camps. Yeah, doc, I'd love to stop it. Let's stop it and see what happens. Or no way, are you crazy? I'm on this drug that's, been keeping my cancer at bay. I don't want to stop. So there's no right answer. And there are some trials going on looking at discontinuing versus continuing. I think there's one through ECOG, but I know there are some going on, not just in RCC, but across, immunotherapy responsive diseases. But it is a question for the field of immunotherapy, not just GU cancers. I don't know, Dr. Hussein, if you have anything to add to that.
No, I fully agree with you. And I think it's complicated, as they say.
Yeah.
Hindsight is always 20/20, obviously. The issue I think comes up in a situation like this is if the patient had 2 recurrences, maybe this is something to consider. And of course, the duration of IO is all driven by what's available in terms of the clinical trials.
Sure. In this patient, I'm glad the patient discontinued and is doing well. And somebody with this multifocal brain disease, I don't know, they just make me nervous. And I might actually lean towards continuing unless there's some good reason not to, but again, nobody really knows. So just to sort of sum up, I think we've certainly talked about this. For this particular patient at this point, there is no future treatment, right? You would just watch them, do periodic scans, including, of course, brain imaging, and then upon recurrence, I guess, then you'd have to talk about, re-inducing them with ipi-nivo or just starting the nivo again. Again, nobody really knows the answer, but I think it's aside from the multifocal brain mets, this kind of patient is occurring more and more in clinic where people have these deep responses, and we're talking about surgical consolidation. So again, I think it's happening anecdotally around the world, I'm sure, but I'm not aware of any good collected published experience yet.